So our next speaker is also a frequent flyer at the Pain Short Course. Andrea, have you come to all of them?
Yes, except for last year.
Yeah, you missed,
I know, I was at the lake.
Yeah. Anyway, Andrea is someone that we've known for a long time. We helped mentor her when she was on her NIH Career Development Award. She was sort of like a K-12 person before we got the K-12. And it helped convince us that maybe we could do this. Maybe we could actually help mentor people from afar. So it's, you're not an old friend, you're a younger friend. But it's been really fun working with you over the course of your career, so.
Likewise. Can everybody hear me okay? Awesome. Well, it's a delight to speak with you, and thank you for inviting me, Dan and Afton and everyone. I always say this is kind of like coming home, even though Kansas is my home. There is no place like that home, but there's no place like this home as well for me. Been a bit of a research baby. I've grown up here, so it's really lovely to be speaking. So I'm going to talk to you today about essentially a new line of inquiry for me. I kind of started in the chronic low back pain space, since then has morphed into work in nosoplastic pain, fibromyalgia, and then through my work with the Gender Diverse Clinic at the University of Kansas, I started becoming very interested in pain and gender minorities, given the referrals that I was getting from their clinic, patients mostly with nosoplastic pain syndromes. So here are my disclosures. So our objectives today is to provide an overview of gender diverse terms and definitions. Just like Roger started out with definitions, I'm going to as well. We're going to examine the prevalence and characteristics of chronic pain in gender minority and gender diverse persons. And then Afton really wanted me to speak on the role for compassionate LGBTQIA plus care in the research setting, because it's very important that we take into considerations what different types of minority groups face when we're interacting with them, not only clinically, but also in the research setting. So terms and definitions. We're going to start with sex assigned at birth. This is obviously the sex that's assigned to an infant at birth based on the external appearance of their anatomy. Gender identity is a person's internal, deeply held knowledge of their own gender. And so you own that. That is yours. It is no one else's to define. Gender expression is the external manifestations of gender that are expressed through a person's name, their pronouns, their clothing, the way they do their hair, etc. Sexual orientation is different from gender expression. It describes a person's physical, romantic, and/or emotional attraction to another person. And it is, like I said, it's different than gender identity. Transgender persons have sexual orientations that can include straight or be on the LGBTQIA spectrum. Cisgender refers to persons whose gender identity aligns to the sex that they were assigned at birth, and transgender persons have a gender identity that differs from the sex that they were assigned at birth. So we're going to take that a little bit further to understand additional terms. Non-binary, you may have heard of, is an adjective used to describe people who experience their gender identity and or gender expression outside of the binary gender categories of male and female. People can also be gender non-conforming. Many cisgender people have gender expressions that are gender non-conforming, but is a term to describe people whose gender expression differs from the conventional expectations of masculinity and femininity. Gender dysphoria is a DSM-5 diagnosis. It has fallen out of favor over the past recent years. You'll hear me referring to that term more as gender incongruence. It will be an ICD-11 diagnosis in the sexual health section. They're expected to adopt that here in the US in 2025. And I'm just going to read this definition verbatim here. As a marked and persistent incongruence between an individual's experienced gender and their assigned sex, which often leads to a desire to transition in order to live and be accepted as a person of the experienced gender through hormonal treatment, surgery, or other healthcare services to make the individual's body align as much as desired and to the extent possible with their experienced gender. So I participate in our gender medicine clinic through seeing patients who experience chronic pain. There are is a variety of different gender diverse medicine roadmaps for the transitioning of persons who identify as transgender or gender diverse. So I'm going to talk a little bit about what the different types of therapies or treatments are that persons who are LGBTQIA, transgender, and gender diverse experience. They can choose to do all of these or none of these or a mixture of these, and that's what's beautiful about helping in transgender and gender diverse medicine is it's really led by the patient. So social transitioning can include a person coming out to friends and family, to coworkers, and presenting as their true gender in public. It can also involve legal document changes. The medical and surgical transitioning is what we oftentimes see at our medical center at the University of Kansas and can include gender-affirming hormone therapy, gender-affirming surgeries, but can also consist of things like laser hair removal, speech therapy, and discussions of fertility preservation. As I said, the goal of therapy for these individuals is to align their body with their true experienced gender. And one of the things that they can do to do this is gender-affirming hormone therapy. And the goal of the therapy is to align their body with their gender identity. And so feminizing therapy aims to induce feminizing changes and suppress previously developed masculinization. So oftentimes estrogens are used plus or minus anti-androgens to achieve these goals. And for masculinizing therapy, this aims to induce masculinizing changes, and this is done through the use of testosterone. And so many studies have shown that gender-affirming hormone therapy, both in the short and long term, not only reduces that gender incongruence, but also improves body dissatisfaction and improves their psychological well-being and quality of life, and for many is truly life-saving care. Just a little bit more about the different types of surgeries you see here. These are all done at the University of Kansas and across different centers across the nation. Interventions can be the laser hair removal, as I've discussed, but it can also involve things like genital tucking and packing, as well as chest binding. And then there is a variety of different surgeries, which you can read through here. It's important to note that not all gender minority persons seek all interventions, and some may actually seek none. And the current standard of care that's set forth by WPATH, which is the World Organization for Transgender Health and Care, is to allow each person to seek only the interventions that they desire to affirm their identity. So we've been talking a lot about disparities with our last lecture, and I'm going to continue to say, just as Roger did, that there is many health disparities for persons who are considered to be gender minorities. And despite recent advantages and advances in the recognition and healthcare for persons who identify as LGBTQIA, these populations still do face disproportionate challenges in accessing certain healthcare services. And we know based on the literature that many gender minority adults have higher morbidity and potentially mortality with increased rates of anxiety and depression, as well as increased rates of substance use, nicotine use, alcohol use, and a higher suicide risk. And as a result, patients who are gender minorities oftentimes have been reported to experience mistreatment as well as a significant amount of medical mistrust when trying to seek care, not only for their gender-affirming care, but for regular health care within the system. I didn't even get to put that last thing. This is why I'm doing the work I do, is the largest barrier to care that is reported by gender minority persons is a lack of providers with the knowledge of the health issues that face their population. And this is really what kind of drove me to start looking into this topic was many patients would say they'd come to my clinic with their fibromyalgia, their migraine, et cetera, and none of their care in their gender-affirming clinics had anything to do with their pain. They weren't even asked about their pain. And when I was asked by them, well, do you know much about chronic pain and gender-diverse individuals? I said, well, there's not a lot of research out there, but I really went in and dove deep into the literature and, again, found that there's not much there. I'm going to share some of it with you now, and then I'm going to share some of the work I've done recently in the space, and then hopefully go forward with some future directions. So there's a few studies here. All of my references are on my slides, but the prevalence of fibromyalgia and migraine headaches has been shown to be higher in minority Medicare beneficiaries that are gender minorities compared to age-matched cisgender controls. And in another study, this one was done by Levitt, showed that in a cohort of 115 gender minority patients, that 19.4% of transgender men met criteria for the diagnosis of fibromyalgia, and that's based on the 2016 criteria. About 7% of transgender women met criteria for the diagnosis of fibromyalgia, and then when they took the cohort as a whole, it was about 14.8% of the entire population, so still higher than the rates in our total population that we typically see reported. So I've talked about the pain. What happens when patients take their gender-affirming hormone therapy? So we know they already have higher rates of chronic pain. What happens when they initiate their gender-affirming hormone therapy? So this is where there's really a black box of studies. There's very, very few that were done, and there's very, very few that were done well with good research methodology. Most of the studies that have been published used a retrospective nature or cross-sectional nature to identify the use of GHT as well as patients who are gender minorities. And they were very heterogeneous in terms of the prevalence of the patients even taking gender-affirming hormone therapy, as well as the duration of the treatment that they were taking. And so there's a mixed bag here when you look. Again, I've listed all of my references here, but there's a very much contradicting evidence here. In one study, they showed no difference in chronic pain between gender minorities and cisgender persons. In another one, they noted that transgender males who were taking testosterone may have decreased bodily pain when they compare it to transgender males who are not taking testosterone. And then a final study showed increased bodily pain and decreased physical functioning in transgender females compared to cisgender women and transgender males. So really kind of all over the place, but when you take the methodology into account, it's retrospective or it's cross-sectional, we really can't get that longitudinal cause and effect here of what truly is happening when a person initiates and begins their gender-affirming hormone therapy and whether that makes a difference on pain whatsoever. So I had the opportunity to collaborate with people who run the PRIDE study out at UCSF and Stanford. Dr. Anessa Flenche is actually from Kansas, so she came and spoke at our grand rounds for the addiction center that we have at the University of Kansas, and had a chance to strike up a collaboration with her. But the PRIDE study is pretty much the country's largest longitudinal cohort study. Anyone who identifies as LGBTQIA+ can go to the PRIDE study website and sign up. It's an annual health survey. You don't have to be in pain. You don't have to have any medical problems, but you can go and fill out questionnaires on your general health, and you can actually do so over time. So I was able to access the 2022 annual health questionnaire. We identified 5,397 patients. We found that approximately 54.6% of that population reported having no chronic pain, but 45.6% of that population reported having some sort of chronic pain. And that was identified through a questionnaire. And then when people answered yes that they have chronic pain, it would take them to the Michigan body map. So good for them using the Michigan body map. And then we were able to take this a bit further to characterize it and identify what our primary outcome was the presence and location of chronic pain in this cohort. And then our secondary outcomes were to look at the presence of widespread pain, which we defined as pain in 3 or more regions of the body, and then associate those with gender identity. We also did sexual identity because all persons in this study are either sexual and or gender minorities, and then look at the total number of pain regions that they have in the presence of widespread pain. So these were our findings that were just recently published, I think just this week in Pain Medicine, which is exciting. Is there a little pointer here? Okay, great. So you can see here, we've got cisgender men. And so I just want to point out, when you see cisgender men, cisgender women, remember that this is a group of LGBTQIA plus individuals. So typically speaking, these persons are still on that spectrum of identity. There are non-binary persons, trans men, trans women, and then another gender individuals. So these are people who don't identify as non-binary, trans men, trans women. They identify as another gender diverse group. And so we were able to look at the different body regions of the Michigan body map. Here you can see that the largest amount of pain was in the spine, so neck, upper back, and lower back. So when we looked at these percentages here, you can see quite high prevalence in percentages of persons with spine pain. And then when we looked at the total number of pain regions, so that's right here, total number of pain regions, it was higher in non-binary, trans men, and another gender persons, as well as the prevalence of widespread pain being more prevalent in non-binary, transgender men, and another gender persons. And then when we did a regression analysis looking at gender identity predicting the presence of widespread pain, what we did find was increased odds ratio groups, as you can see here, for all gender minority groups for the presence of widespread pain, and we use cisgender men as the reference group. And one thing I really loved about working with the PRIDE study, and I encourage any of you who are interested in sexual or gender minority healthcare to consider working with them. You get to apply to do a study with them. It gets reviewed by an advisory board, which is consisting not only of providers, but participants and community members. And one of the number one things that is that they hold true to is making sure that the results get disseminated back to the community. So they made this infographic of our study, which I thought was really great. It's on their Instagram. And I had a chance to present last week to their community advisory panel. And it was just a really wonderful experience because I feel like so often this is what we get to present to, but to be able to talk to the community and provide the information that you're doing for their community to that community is just really wonderful. So I just wanted to show that because I was really proud of it. We did a follow-up study here at the University of Kansas. We recruited 103 persons out of our gender diverse clinic. We also run it's a student-led free health clinic called the JDoc Free Clinic. And they have a gender affirming night where they provide free gender affirming care to low socioeconomic status persons living in Kansas City. We did validated pain questionnaires, all of the pain phenotyping outcomes that I've been trained to use in my studies. We had approximately 28 persons who identified as transgender males. We had 48% identifying as transgender females. And then we had 28% that were other gender. I do want to notate that these are all persons who are assigned female at birth, or what we call AFAB. One thing that after listening to Roger's study, and I also had the chance to meet with some of our trans persons of color in our Kansas City community to present my results to them as well. The makeup of Kansas and Missouri is quite heavily skewed to a Caucasian population. We were able to recruit some other ethnicities, and I apologize for my typo there, that should be Latinx, but overall a non-Hispanic Caucasian population. And approximately 93% of them were taking hormone therapy with an average duration of about 800 days. And when we did the analysis of the entire cohort, I'm going to show you our subgroup analysis next. 48.5% of the entire cohort reported the positive presence of chronic pain. So this is very high levels, high prevalence of chronic pain that I was not even expecting to find when we first sought out to do the study. So we broke down our subgroup analyses. Our manuscript is currently in preparation. Transgender male, transgender female, and then other gender persons, again, all assigned female at birth. And when we look at the pain phenotyping questionnaires, what we find across the board is that transgender males and other gender individuals have increased pain interference, increased pain severity, higher fibromyalgia scores, higher scores on the perceived stress scale, that were all statistically significant. And then we use the COPC screener. Where's Dave? Plug for the COPC screener. We were able to utilize that, and I'm going to be using it in all of my studies now because I just find it to be so helpful. But interestingly, we found statistically significant differences in the number of COPCs in transgender males and other gender, looking fairly similar. But compared to our transgender female population, they have higher amounts of chronic overlapping pain conditions. We took it another step further and we decided to look at persons who were taking masculinizing therapy versus feminizing therapy, and essentially found the same type of trends. Persons who were on masculinizing therapy had statistically significantly increased levels of pain interference, pain severity, fibromyalgia, perceived stress scale, and chronic overlapping pain conditions. So this is hopefully going to be published soon. We're really, excited to see the data. I don't know if anything like this has been published before, but we're looking forward to doing more work in this space, really to kind of carve out what's the longitudinalness of all of this. What happens over time when we look at baseline and then initiate hormone therapy? What happens to the pain? So I'm going to talk a little bit about research considerations, ethical considerations for working with this community. I have a current grant pending, and all of these were utilized in me developing the protocol to ensure that we are doing this research with the utmost responsibility to a already disenfranchised and marginalized community. So this group, this is a really wonderful paper. I just put the summary here of what they recommend when interacting and engaging in research with gender minority populations. So whenever possible, research should be grounded from inception to dissemination in a meaningful collaboration with community stakeholders. Language and framing of transgender health research should be non-stigmatizing. The research should be disseminated back to the community. Again, kind of goes back to the PRIDE study, how they do such a good job with disseminating it in a way that can be easily digested by the community. We want to ensure that the diversity of transgender and gender diverse communities should be accurately reflected and sensitively reflected. So something that I am going to be pursuing moving forward when I do research at the University of Kansas on this is ensuring that I'm engaging a more diverse community. I think when I spoke with the leaders of the community, it was a very humbling moment, and I think I was able to recognize my privilege and the privilege of working at a tertiary care center in that moment, to know that there is much diversity out there, but they might not be able to access the tertiary care center gender diversity clinic at the University of Kansas, whether it be to lack of insurance, lack of means. And so I'm going to be hopefully looking at unique ways of engaging with a larger community outside of my little KU bubble. We also want to make sure that informed consent is meaningful without coercion or influence. The protection of confidentiality should be of paramount concern. Alternative consent procedures for transgender minors, and research should align with current professional standards that refute conversion, reorientation, or reparative therapy. And I was very lucky that our IRB got all of our studies through very, very quickly, and I think they recommend that the IRB should definitely make sure that they do not halt anyone looking to try and do research in this wonderful population. So this is another study that actually got published, I think, last week. It's more of a review article that I did with some colleagues at the Mayo Clinic and across the country. But these are just some, I think it says practice considerations, but I think you could look at this as research considerations as well. Asking the patient their pronouns, providing your pronouns to the patient, asking them how they identify, making sure that you use their correct name and their correct pronouns throughout their entire visit. And then utilizing that trauma-informed approach, recognizing that, talking to them, creating that place for safety. I think the panel we had at the very end, making sure that patients have a space that is safe to talk, they feel physically and emotionally safe, that there's a sense of collaboration and trustworthiness is a really important facet to hold as you're engaging with this community. Additionally, you have to recognize that anytime a transgender or gender diverse person comes into a medical space or even a research space, it can be highly stressful for them. There's the potential for dysphoria-inducing interactions that I didn't even have a chance to go over today, what those might be. But even just like a pregnancy test can induce dysphoria in persons. So you always need to be thinking about how you can reduce those interactions and make them as open and safe as possible. And again, that idea that trauma-informed care includes safety, trustworthiness, and transparency, collaboration, and mutuality, empowerment, voice and choice, and then taking into account their cultural and historical issues as well. I work with my team. We engaged with 103 patients, and my team was very concerned about making sure that they approach this research in a responsible way. So what did we go over? Well, you should consider to provide your name, your pronouns, your identity, and you should do that to make them know that you care about these things. And then ask them, would you be comfortable sharing your gender identity with me? Would you be comfortable sharing your pronouns with me? And that allows for that space of trust and mutual collaboration and respect. Misgendering is referring to a person with their incorrect pronouns, and it does happen. I've done it. And it's just a natural potential thing that could happen. And basically, if you do it, you apologize. You just apologize. You say, you know what, I recognized I used your wrong pronouns. I am so sorry for that, and I will make sure that I do better moving forward. You should always avoid what we call dead naming a patient. Many patients have their correct names that they use, but at least on our charts at the University of Kansas, their actual legal name is used, but we do have a space to have their nickname or what they prefer to be called. You should always do a good solid service to them by using the correct name that they chose. Be mindful of the power dynamic. Make sure you sit at eye level, speak clearly, and develop a shared agenda, and then ask only medically necessary questions. Establish and use preferred terms for body parts. So what's next? With cautious optimism, we are hoping to do this study. I've assembled a really wonderful team, including my colleagues here at the University of Michigan, and we really are excited to do a study where we aim to longitudinally follow patients as they initiate their hormone therapy. We'll be looking at pain trajectories, characteristics, phenotyping, doing quantitative sensory testing. Steve, thanks for teaching me everything you know. I still have so much more to learn. Chelsea will be working with us on brain neuroimaging, and then Dr. Laura Black, where are you? She'll be doing our qualitative studies. So I'm very interested in doing this qualitative work because pain is just more than physiologic processing. There's a lot of different aspects that need to be addressed, and understanding pain, bodily pain, emotional pain, gender-affirming care, and the experience of pain, and we look forward to doing that through qualitative interviews. So I just want to say it takes a village, and I'm so thankful for the support I've had here at the University of Michigan, colleagues at UCSF, OSU, back there, Dr. Black, and then my wonderful team of queer and gender diverse women that I've been able to hire and just love working with. And thank you for being part of my own journey.